Okay, this is the INI May 2025 ENT question discussion. Okay. So, my dear friends, let us see which question came out of ENT in INICET May 2025 session. The first question was a little atypical. After an ear infection, a child had limb spasm, pain, and difficulty in opening mouth. So, child has trismus also and limb spasm also. Guys, unsafe CSOM or attico-antral CSOM is characterized by the presence of cholestoma in the middle ear cleft, and cholestoma has got bone eroding properties. So this is your neuroanatomy picture, very famous picture, and we see this is your ear. Now ear is located in which bone? Temporal bone, and cholestoma has got bone eroding properties. If cholestoma goes up and the erodes the temporal bone and infection goes up, it can lead to meningitis, or it can cause brain abscess formation, or it goes backward, it can lead to sigmoids and a thrombosis formation, or it can cause mastoiditis also. So chronic foul-smelling ear discharge is suggestive of unsafe CSOM or attico-antral CSOM. Various complications can be interpreted from the symptoms given in the question. If the question says chronic foul-smelling ear discharge with vertigo, only vertigo, think of labyrinthine fistula of lateral semicircular canal. If they say chronic foul-smelling ear discharge with headache, vomiting, and neck rigidity, think of meningitis as a complication of unsafe CSOM. And if they say chronic foul-smelling ear discharge with headache, vomiting, and convulsions, think of brain abscess, most commonly seen in temporal lobe. Get a CT scan done, and treatment is neurosurgery. And this is sigmoid and thrombosis. How this question will come? Chronic foul-smelling ear discharge with headache, spiky fever, and pitting edema on the mastoid. And that pitting edema on the mastoid is called Grissinger sign. And this is purely picture of sigmoid sinus thrombosis or lateral sinus thrombosis. My dear friends, edema on the mastoid with ear discharge can also be seen in mastoiditis. But in mastoiditis, there is no headache. Headache in ear discharge is indicative of intracranial infection. But look at this question. This question profile is not fitting in any of these. Patient has got limb spasm and the trismus, difficulty in mouth opening. My dear friends, this cannot be sigmoid sinus thrombosis. Of course, not myelopathy. What is Bizold abscess? Bizold abscess is a complication of untreated acute mastoiditis when the pus tracks along the tip of the mastoid into the middle part of sternocleidomastoid muscle, and there'll be an obvious middle part of the neck swelling in the lateral aspect. That is Bizold abscess along sternocleidomastoid as a complication of acute mastoiditis. The only answer left in this question is tetanus. So this is a case of otogenic tetanus, which is little uncommon reason of tetanus, but ear discharge can also be reason behind tetanus. The Clostridium tetani and the ear discharge causing limb spasm and trismus or lockjaw is typically suggestive of the diagnosis of otogenic tetanus. Answer to the question is A. Next question. Which of the following are indication of cochlear implant surgery? Cochlear implant does direct electrical stimulation of cochlear nerve endings. You put an electrode into the scala tympani of cochlea through the round window. Now, in which case you're putting it? Most of the time, it is being, used for the children deaf since birth, prelingual deaf child who was born deaf. And if you do the BERA in that case, you will see bilateral profound sensory neural hearing loss. That is the most common thing. The second indication is postlingual deaf people. The postlingual deaf, what are the causes? For example, the ototoxicity. Somebody is given aminoglycoside like streptomycin, gentamicin, amikacin for a longer duration, higher dose. This is causing irreversible damage to outer cells of the cochlea. And this is the typical scenario of postlingual deafness. So guys, please see. So what are the indications of cochlear implant? Of course, congenital hearing loss, yes, which is bilateral profound SNHL, and otoxicity-induced hearing loss. So this is prelingual deaf, and this is postlingual deaf children. In otosclerosis, we do not use cochlear implant. In otosclerosis, we put the stapes piston processes, and the name of surgery is stapidotomy or stapedectomy. Fixed malleus would not be benefited with the cochlear implant because the problem lies in the middle ear. So the answer to this question is 2 and 4. So answer is 2 and 4. Answer is B. B. Angiofibroma, juvenile nasopharyngeal angiofibroma, which of the following is incorrect about? First of all, you know that angiofibroma is a highly vascular tumor, typically seen in young adolescent males of 12 to 18 years of age. Why this tumor is presenting with recurrent perfuse epistaxis? Because it is made of blood vessels, and on top of that, the blood vessel which make this tumor do not have muscular layer. So once cut, they cannot contract or retract. Therefore, the patient has got recurrent perfuse epistaxis. Generally, patient has got unilateral nasal mass and recurrent perfuse epistaxis. There can be cheek swelling or dull voice or conductive hearing loss due to glue ear. My dear friends, the investigation choice is CCT in this case with angiography, and CCT shows which sign? Holman-Miller sign or antral sign. The biopsy is contraindicated. So answer the question is D. Biopsy done under local anesthesia is not the ideal investigation in this case because of the vascular nature of the tumor. So recurrent bleeding, yes. The unilateral nasal blockage, yes. Adolescent male, 12 to 18 years, yes. So answer the question is D. Now, next question. A patient experiencing vertigo and vomiting, specifically while turning in bed. The history is very important. Positional vertigo. I think one most important cause of positional vertigo is BPPV, benign paroxysmal positional vertigo. Other vertigo like Meniere disease, labyrinthitis, neuritis, they are not positional vertigo. What is BPPV? Benign paroxysmal positional vertigo, which is the commonest cause of peripheral vertigo, more common in females. What is the cause of BPPV? Basically, the otoconia or otolith migrate from the utricle saccule area to the semicircular canals. Typical history will be vertigo for few seconds, vertigo for few seconds on changing head position with a little bit nausea, vomiting, but there is no hearing loss, no tinnitus because cochlea is absolutely normal. My dear friends, how to diagnose it? Dix Hallpike maneuver is diagnostic of BPPV. Apley maneuver is therapeutic for BPPV. In Meniere disease, the vertigo is for few hours and it is not positional vertigo. And in Meniere, there's a triad of episodic vertigo with tinnitus and hearing loss. The vertigo of neuritis or labyrinthitis is for days, many days. The answer to the question is A. Stridor in newborn is common in which of the following conditions? What is stridor? Noisy breathing. What is the cause of stridor? The airway obstruction. The whenever air passes through a narrow chamber, it generates a sound. In this area, it's called stridor. The laryngomalacia is the most common congenital anomaly, and it is the most common cause of neonatal stridor. So definitely laryngomalacia in newborn is the commonest cause of neonatal stridor. Number two, congenital subglottic stenosis. Yes, it's also very important. What is subglottis area? It is space in the cricoid ring. If the cricoid ring is small in size, this diameter is small, then it is subglottic stenosis. And I hope you remember Cotton-Meyer grading for the congenital subglottic stenosis. The grade 1 is 0 to 50% obstruction. Grade 2 is 51 to 70% obstruction. Grade 3 is 71 to 99% obstruction. And grade 4 is no lumen detectable. In Kottama grading, you have to keep in mind for the grade 1, you don't need any treatment. But for grade 2, you would have to go for the laser dilatation followed by topical application of mitomycin C. And grade 3, grade 4 need proper surgery, laryngotracheal reconstruction. After that, you put the Montgomery silicone tracheal T-tube. My dear friends, in congenital subglottic stenosis also, there is a very significant stridor with the respiratory difficulty. But laryngeal papilloma, the juvenile papillomavirus, the new name is recurrent respiratory papillomatosis, which is caused by human papillomavirus 6 and 11. This is seen in typically in 3 to 6 years of age. The question says that neonates, newborn. It is not newborn. Juvenile papillomavirus is seen in 3 to 6 years of age. So that cause is ruled out. Hemorrhagic polyp, on the vocal cord due to vocal trauma, shout a lot. And suddenly there is a single polyp formation over there. This would not cause stridor, and this will mostly be your adult problem over there. It will be mostly of adult problem out there. And the answer to this question will be, of course, the 1 and 2. 1 and 2. And that's why the answer is A in this case. A in this case is the answer. Okay, fine. So, stridor in the newborn most commonly seen due to laryngomalacia. Other causes are congenital subglottic stenosis. It can be seen in the congenital laryngeal cyst also, and to some extent to congenital subglottic hemangiomas also. Now, the next question. Piriform fossa is injured due to fishbone. Which nerve likely to be damaged? Indirectly, he's asking you that sensory innervation of piriform fossa. I hope remember, if you see this is your supraglottic area, on the both side, if you put an arrow over there, this is the part of laryngopharynx or hypopharynx, and this is called piriform sinus. Internal laryngeal nerve, which is actually the internal branch of spinolaryngeal nerve, it gives sensory innervation to supraglottis and piriform sinus also. Okay, so by chance the fishbone is stuck over here. Imagine this is fishbone. Fishbone is stuck over here. While removing fishbone, by chance, if you damage the internal laryngeal nerve, where was the foreign body stuck? Piriform sinus. Or if the fishbone has injured the mucosa of the piriform sinus, which nerve could have been injured? Internal laryngeal nerve. If you put a cotton soaked in xylocaine in piriform sinus region, which block you are giving? You are giving internal laryngeal nerve block. A lignocaine soaked cotton pledget kept in piriform sinus is which block? Internal laryngeal nerve block. My dear friend, internal laryngeal nerve, it passes thyroid membrane to enter the larynx, supraglottic area. Okay, fine. Internal laryngeal nerve, it gives sensory innervation to supraglottis and piriform sinus. And internal laryngeal nerve is actually entering through which membrane? Thyroid membrane to enter the larynx area. So these were the various questions which were asked in the INI-CET May 2025 examination.